Evidence-based practice related to oral care and ventilator-associated pneumonia. Ventilator-associated pneumonia, or VAP, occurs 48 hours after intubation as a result of pulmonary inflammation after mechanical process of intubation compromises the natural barrier between the oropharynx and the trachea, facilitating the entry of bacterial pathogens into the lungs. Ventilator-associated pneumonia is one of the most frequently occurring hospital-acquired infections in intensive care units, affecting 10 to 30% of intubated patients. The presence of VAP is linked to increased morbidity and mortality and can increase the length of hospital stay by at least 5 days, as well as accrue an excess cost of approximately $40,000 over the average healthcare cost of the ICU patient that does not acquire ventilator-associated pneumonia. Adherence to an oral care protocol containing chlorhexidine significantly decreases the incidence of VAP. Chlorhexidine is an antiseptic agent that is included in oral care protocol products of intubated patients. It binds to oral tissues and has a slow release of antiseptic properties. Therefore, it provides a long period of antibacterial action. Evidence-based clinical practice guidelines to reduce VAP have been available for several years. There is an abundance of scientific and scholarly articles with supporting data that the adherence to an oral care protocol using chlorhexidine significantly decreases the incidence of VAP. Unfortunately, these guidelines do not always bring about changes due to the inconsistency of nurses and other clinicians incorporating the evidence into their practice. Because of this inconsistency, ventilator-associated pneumonia continues to remain a costly and frequent complication of mechanical ventilation, making it a significant healthcare issue. This leads to the following PICO question. In the adult critically ill patient, how does the adherence to an oral care protocol using chlorhexidine compare to non-adherence to an oral care protocol in reducing ventilator-associated pneumonia during the intensive care unit stay? The conceptual model and its framework that fit the presented PICO question is Anderson's Health Behavior Model for Healthcare Utilization. The framework of Anderson's model will be used to explain factors that influence patient outcomes and the effectiveness of nurse adherence to an oral care protocol with chlorhexidine. Anderson's model includes 4 parts: population characteristics, healthcare system, use of health services, and consumer satisfaction. Each of these factors may influence the number of hospital-acquired infections as it relates to ventilator-associated pneumonia. Population characteristics includes predisposing factors. These factors include poor oral hygiene practices prior to hospitalization, as well as factors that can be noted after an oral exam, such as a dry mouth, edema, inflammation of the gums and tongue, ulcerations of the oral mucosa, debris and plaque on the teeth, and the condition of the saliva. Enabling refers to resources available to the patient, such as hospital-provided oral care kits. Personnel trained and educated about the proper use of these kits are also considered resources. The need determinant refers to the nurse's perception of the need for appropriate oral care for the critically ill intubated patient as it relates to the prevention of VAP. The healthcare system is another crucial determinant of patient outcomes in the prevention of VAP. Evaluation and reinforcement of existing oral care policies should be considered. The product availability and cost effectiveness should also be considered. Sage is the most popular company to offer comprehensive oral care products. These products have been clinically proven to deliver an oral hygiene program that decreases VAP risk factors with appropriate use. The cost comparison of using the product to the cost of a VAP patient's stay in the intensive care unit and treatment is remarkable. But if a facility cannot afford the product, is unaware of its effectiveness, or is unwilling to contemplate its use, patient outcomes cannot be measured. The use of healthcare services includes type. In this case, the type refers to an adult intubated patient in the critical care unit. It also includes purpose, and this refers to the adherence by nurses to an oral care protocol using chlorhexidine to prevent ventilator-associated pneumonia. The time interval is the time spent in the intensive care unit. Consumer satisfaction serves to describe reasons why quality oral care products may or may not be used in a facility. It looks at the convenience of the product, the quality of the product, availability, financing, and provider characteristics. In this study, it will be assumed that the user is a critically ill, intubated patient with a high risk of developing ventilator-associated pneumonia. And Anderson's model will describe the factors that affect positive patient outcomes when the nurse adheres to an oral care protocol using chlorhexidine to decrease the incidence of VAP. Articles for this study were retrieved from the electronic database ProQuest and Medline. Keywords included oral care, ventilator-associated pneumonia, chlorhexidine, hospital-acquired infection, intubated patient, and oral care protocol. There is an abundance of scholarly and peer-reviewed articles on this topic. In addition to retrieving articles specifically related to research findings of using chlorhexidine in the prevention of VAP incidents, attention was given to scholarly articles that related specifically to nurses' adherence to an oral care protocol using chlorhexidine for ventilated patients in the prevention of VAP. Other scholarly articles were retrieved from the websites of the American Association of Critical Care Nurses, the Centers for Disease Control and Prevention, and the Sage Products website. The ethical considerations include risk assessment. The risk assessment in the study focuses on risks to the individual research participants that did not receive adequate oral care, and the benefit assessment focuses on the benefits to future ventilated patients when an appropriate oral care protocol is adhered to. The risk-benefit ratio is based on the principles of non-maleficence and beneficence. The studies that pose great risk must have potential for a great benefit in order to be justified. As for fair subject selection, a study that examines the outcomes of care provided by nurses, in this case oral care, could be ethically problematic in that future patients who will benefit from the study may not be fully represented by the patients enrolled in the study and exposed to its risks, leading to a potential violation of fair subject selection. For exclusion criteria, the patients that meet the study criteria should have an equal opportunity. There must also be justification for excluding certain groups of subjects. Potential grant sources to fund this study could come from the American Association of Critical Care Nurses. This association supports critical care nurses that seek evidence that will ensure excellent care and safety for patients. According to the website, the AACN Impact Research Grant is designed to ensure a source of clinically relevant research for creating the evidence-based resources that influence critical care nursing practice and should generate new knowledge. The Centers for Disease Control and Prevention could also be considered an organization to request funding from, due to the agency's strong advocacy for infection prevention and policy adherence. And then the Department of Clinical Affairs, which is supported by Sage Products, funds educational needs that are focused on the clinician's understanding of the scientific, ethical, and healthcare issues that contribute to enrichment of patient care. Support is also provided for educational activities that enhance the clinical and medical knowledge and skill of healthcare professionals. In conclusion, oral care policies incorporating the use of chlorhexidine are present, but they are not well used. Ventilator-associated pneumonia remains a significant issue. Nurses may not be aware of published guidelines, and there is a gap that exists between national oral care standards, reported oral care practices, and unit-level oral care policies. Current oral care practices do not match evidence-based recommendations. To implement the practice, it would require a review and revision of existing oral care policy and guidelines. There's a need to identify barriers to delivery of oral care, which could be the conception that it is time-consuming, it is cumbersome, there's fear of dislodging the endotracheal tube, the toothbrush or sponge toothettes are not available or easily accessible. And some nurses are unsure of the ventilator-associated pneumonia rate in their unit. and how it relates to delivery of oral care. The staff would need to be re-in-service using various strategies, standardized oral care documentation, and ensure required equipment is available and easily accessible. These practices could improve nurses' practice and adherence to an oral care protocol that can